Hey lovelies. I welcome you back to our session of emergencies, and my baby welcomes you too. Guys, welcome back to my channel. And if this is your first time, please press the subscribe button so that you get a notification every time I make a new video. And if you're a returning subscriber, thank you for watching. I appreciate your effort. Let's share this knowledge. Let's share with everyone that you think we need to know about the midwifery OSCEs, okay? Feel free to recommend it to your relatives, your friends, and come back again and watch, okay? Let's take load. Let's form a community. But guys, if you want clarity on anything, or if you feel there's something I didn't explain so well, or that you need details on, kindly just comment in the comment section and I will get back to you, okay? So today we're going to look at another emergency, and that is the shoulder dystocia, okay? Stay tuned. Let's get in. So we're going to start with marking criteria, and then we shall go on to see how we do it. Okay, I hope we are together in this. And let's get to keep this in mind, that every time that you notice this is an emergency, the first thing when you're starting to explain to your assessor is that you have to claim, or you have to notify that this is an emergency, and also let the mother know this is an emergency. Secondly, you have to call the emergency buzzer. The emergency buzzer, whereby you're going to call 99999 if you're in the community, and you're going to call 2222 if you are in a hospital setting. Okay, I hope we are together in this. Okay, so, and then that will bring on the multidisciplinary team. And the multidisciplinary team, as we talked about, is having the senior midwife, having the obstetrician, having the pediatrician, okay, having the scribe, having the anesthetist, and having other midwives. Are we together? Those are the main must-knows when you're doing an emergency, okay? So let's get in. Let me not take your time. Let's get in and ciao. Just as always, I'm going to give you two ways of how to do it. I prefer two ways because everyone has something that, oh, I can easily go by this. The main thing in this is you're able to accomplish the station. You are able to accomplish what is in the marking guide, okay? So do you see this? Yeah, just as they say, there are many ways of killing a rat, and this is it. Anyways, I'm going to begin with reading the assessment criteria of the shoulder dystocia. Yeah, let's get in. So number one, recognizes the emergency and calls for help. Recognizing the need to use the emergency buzzer, declares the emergency, clearly stating shoulder dystocia, and recognizes the need to request for assistance from the appropriate members of the multidisciplinary team. Verbalization is accepted. So then number two is asks the woman to stop pushing, reclines the back of the bed or couch, and removes any extra pillows behind the mother's head, and considers moving the end of the bed. Considers removing the end of the bed or supporting the woman to the end of the bed, like to the edge of the bed, okay? Then carries out the McRoberts maneuver and attempts to deliver the baby. Applies suprapubic pressure on the side of the fetal bag. That is done by your assistant. Those people that you've called, the team we've called, they are the ones who help you to apply the suprapubic pressure. Evaluates for episiotomy. Verbalization accepted, okay? Remember we said you do Pringle-like hands on the perineum so that you evaluate for episiotomy to see if the vagina you're dealing with is roomy. So you need to talk about it, because most times you're not going to cut the dummy. Then attempts to deliver the posterior arm, attempts internal rotation maneuvers, and then 8 supports the woman to roll over onto all fours and verbalizes the possible benefit of change in this position. But remember, it also depends on the mother you have. So if this mother has already got what is it called, I'll explain in the when I'm going into the how to, because not every mother will be able to go on all fours, okay? And you explain to the mother that changing this position may help to release the shoulders, okay? So then you're going to explain that verbally considers additional maneuvers as the last resort, cleidectomy. So, and that's cleidectomy, cephalic replacement, or symphysiotomy, okay? Then verbalizes the need for the midwife to ensure the woman understands that understands what has happened and has the chance to bond with the baby. 11a, verbalizes the importance of maternal observations to establish condition, okay? Remember we said the maternal observations should look at is the bleeding, maternal blood pressure, the pulse, you know, all those, the 6 that we've always been talking about, and then also the well-being, okay? Then 11b verbalizes the importance of newborn observations to establish condition. So, like the clavicle fracture or the difficult delivery. Then verbalizes the importance of completing all relevant documentation, including the anterior shoulder at the time of dystocia, the contraprenas documentation. I think yesterday I explained that in the in one of the videos, or you can just Google about it, meaning of contraprenas documentation. Then there is debrief and there is detics. Debriefing, in debrief, you debrief the mother and you debrief the team, the multidisciplinary team who came to help you. Detics, in the detics you write about the incidents, what happened, okay? So then we go on to act professionally throughout the procedure in accordance to the NMC 2018, the code, the professional standards of practice and behaviors for nurses and midwives, nursing associates. So that's the marking criteria done. So we're going to go into the how-to. Yay. How's everyone? How is God keeping you? Well, let me see. No, let me begin with this one. So in this station, we assume that you're already in the process of delivery and you know the mother, and the mother knows you, okay? Then I have already drawn my curtains for privacy. Remember, you're speaking this and you're speaking this to assessor, okay? I've already drawn my curtains for privacy and dignity. I've already put on my apron and gloves, and I've already washed my hands according to the WHO policy. Okay, mommy. My mother is always Jamila. Okay, Jamila, I can see the delivery of your baby's shoulder is delayed. This is an emergency situation, which is called shoulder dystocia. So, and then inform the mother this is a bone-to-bone situation. So, please listen to the instructions that I give you. Is that okay? Okay. So, say to her, Jamila, do not worry. We will deliver the baby safely, and I'll call for help. Okay. A team will be coming here, but don't get scared. Like, stay calm. They're coming to help us. Okay. So, I'm going. So I'll pull the emergency buzzer. So Jamila, I'll pull the emergency buzzer, which is 22222. In this case, we are in the hospital. That's why we are pulling 2222. Okay. So I'll call the the multidisciplinary team, which is the senior midwife, obstetrician, anesthetist, the scribe, or other midwives. Okay, then Jamira, can you please stop pushing? You have a shoulder dystocia, and this is a bone-to-bone problem, and if you continue pushing, it will cause injury. It may cause injury to our baby. Okay, I'm going to lay back the bed of your bed and remove extra pillows. Also, I'm going to check the resuscitator and the delivery pack, and check the windows are closed to bring the buttocks to the edge of the bed. This is to make sure the mother is completely safe and everything is ready to do what? To handle the baby and the mother. Okay, so I'll go on and ask my assistant to help me do my first maneuver, which is the McRoberts maneuver, which is hyperflex the mother's leg towards her abdomen. So let's assume this is Jamira. So hyperflexing the mother's legs until the abdomen is this. Let's say the mother's leg is like this. So you do like this. Assume this is the mother's legs. But this, when they are folded, my baby cannot fold, but hyperflexing them. So this is it. So towards the abdomen, and then applying the routine exotraction to deliver the head. Not longer than 30 seconds. Okay, so then you ask the mother, is the baby coming? Okay, if no, then I'll put the mother on all fours, because it could have the same outcome. So those are the two positions that we have for this. Okay, but the all fours will be on. So then I'll do my next maneuver, which is to apply suprapubic pressure from the side of the fetal bag to the maternal symphysis pubis in a downward and lateral direction for 30 seconds. And then I ask, is the baby coming? Okay, so then we shall go on to, before I do the internal maneuvers, then I'm going to assess my perineum for an episiotomy. So this will not fix the shoulder dystocia, but it will give us more space to have a roomy vagina. So then you are going to ask your examiner, Madam Examiner, do I have enough space to enter the vagina? Is the space adequate? Okay. So I'm going to do my internal maneuver and try to deliver the posterior arm. I'm going to put my fingers in a Pringle shape. This is a Pringle shape, and insert the sacral hollow. Once the posterior arm is located and the wrist is reached, the arm will be delivered in a straight line, as if putting the hand up in class. This is once you locate the arm. So that's how it comes out. My God, these demonstrations. So once delivered, then you apply exotraction. Let's go on. So if the baby is not delivered, apply an internal rotation maneuver, which rotates the posterior arm either at 10 o'clock or 2 o'clock. Apply pressure to either the interior or the posterior aspect of the posterior shoulder, and ask the assistant to apply suprapubic pressure on the opposite side if it is necessary. Or try the one and then apply routine exotraction to deliver the baby. Okay, if the baby is not delivered, support the woman to roll over on all her fours and repeat all the maneuvers. If the baby is not yet delivered, transfer the mother to theater to do symphysiotomy or celiotomy. So celiotomy is an incision that is made into the abdominal cavity. Okay, and then or they can do zavenally, ZAVANELLY, and this is an obstetric maneuver that involves pushing back the delivered fetus. It involves pushing back the fetal head, which is delivered, into the birth canal in anticipation of performing a cesarean section in cases of shoulder dystocia. Okay, so most times the head has come, remember, and the shoulders are obstructed. Okay, so intravenally is whereby they'll be forced to push back the baby's head in so that they can do a cesarean section, and they'll deliver this baby by cesarean. Okay, then also we can look at if the baby is okay, clamp the cord between 3 to 5 minutes and then take off cord blood. So take off the cord blood for gases and check for the gases. So when the cord gases, the analysis helps the doctors to detect if a child suffered an injury during delivery. So the cord blood gases also show whether the baby is experiencing acidosis, which can indicate that there was hypoxia or an ischemic event during the delivery. So in this, the pH will be between 7.18 to 7.35. Okay, then the POC2 will be between 2 to 32, and the POC2 will be between 32 to 66 mmHg. Then after the procedure is complete, I'll remove my gloves and apron and dispose them off in the clinical waste bin. Remember, we have the yellow bin there, so that's why you put the gloves, the apron, and then I would provide postnatal care for the mother and active third stage management. You don't need to conduct the third stage management, you just talk about it. Okay, so I clean my hands according to the WHO steps. Remember, there are 8 steps. Okay, and then I'll debrief the patient and the staff, do attachment in retrospective as close as possible to the event, do a set of observations on the mother and the baby, and ensure the baby is received by the pediatrician for a birth injury. Okay, remember, the pediatrician was part of our team, that the multidisciplinary. Let's go to part 2 of how to. Okay, so let's assume my mother is still Jamira. Okay, so I'm going to come and say, oh, hi Jamira. She already knows me, but this is for those who love introducing yourself. So I'll just come, oh, hi Jamira, my name is Sarah, I'm the midwife who's going to be working on you. I've been told that you're delivering a baby. Okay, let's go ahead to deliver the baby. Okay, oh Jamira, let me first see the condition of your baby. So I'll take the fetoscope and auscultate to know if the baby's if the baby's fetal heart rate is still okay. Okay, then I'll go on. Hi Jamira, I'm seeing the head of your baby. Go on and push. Okay, but then it's more than 10 minutes. The shoulders are not coming out, which means that I'm having a shoulder dystocia. Okay, so Jamira, we are having a shoulder dystocia. Do not panic. You'll be seeing people around the room, but I'm going to call for help. Okay, so I'll go on and press my emergency buzzer and call 22222. Remember, 4 2s. Okay, and tell them that my name is Sarah. I'm in labor ward room number 22 and I'm having a shoulder dystocia. Kindly come and help me. So whereby I'll call the senior midwife, obstetrician, pediatrician, anesthetist, and the scribe. Okay, then I'll tell Jamira to come to close to the edge of the bed. Jamira, can you please come close to the edge of the bed? Okay, so I'll provide more privacy to the lady by closing all the curtains and the adjacent windows. Wash my hands. So Jamira, can you please stop pushing until I tell you, until I give you instructions on what we're going to do, okay? So the first thing I'm going to do, Jamira, I'm going to apply the McRoberts maneuver. Is that okay with you? Okay, so you're going to flex your legs towards your abdomen to create more space for the shoulders to be born, okay? Then I'll apply my exotraction to see if I can deliver the baby, okay? So the shoulders are still stuck, and even after the McRoberts maneuver. Okay, Jamira, you can stop pushing. The baby is not coming. Then I'll do external rotation of the shoulder, okay? So I'll ask one of my colleagues who have come to apply pressure on the suprapubic area to see if the shoulder can go under the anterior posterior angle to be delivered, as also I do the exotraction of the baby, okay? So the baby is not coming out, which means the baby is still stuck, okay? So then I'll apply the internal rotation of the shoulder, where I will tell my colleague to continue with the traction. I will also look into the perineum to see if I can give an episiotomy. Then I'll confirm with the examiner. Madam Examiner, I feel there's no need to give an episiotomy. I have enough space in the perineum. Is it okay? Can I continue? Okay. Then I will handcuff my hands into a Pringle-like manner, access the posterior shoulder, instruct her to move to and go on to rotate the shoulder to the opposite direction when I bring my shoulder into the oblique diameter, and I'll see if I can deliver by exotraction, okay? So, but our baby is still stuck, the baby is not coming. So now I'll instruct my mother to go on all fours. So this will help us to create more space for the shoulders to see if the baby can be delivered, okay? On all her fours, I'll try to deliver with exotraction. If the baby is not coming, I will repeat the whole process of what I have done. If it does not work, the doctor will take the mother to theater, push back the head. Remember the zonally I told you. Push back the head and do an emergency cesarean section, okay? If the baby is still not delivered in labor ward, then so I will receive the baby, dry the baby. No, wait a minute. So if the baby is delivered from theater, I will receive the baby and examine the baby to see the baby's condition, okay? So in case let me see what else. Then wait for the mother to come out from theater. So when the mother comes back, I will debrief the mother about what has happened, and telling her that she had a shoulder dystocia and everything failed, so that's why I had to do an emergency cesarean section, but everything is okay now, okay? So I'll go on and debrief my colleagues and tell them what, when, why, and what I've done, okay? I also do my documentation and ethics, and then the pediatrician will take the baby for assessment to see if there is any birth injuries to the baby, and then if the baby is okay, we shall do skin to skin and breastfeed the baby with the mother. We shall also continue monitoring the mother for PPH, because she had a difficult delivery and is prone to getting PPH, okay? Whereby we shall also continue monitoring her vitals to rule out any signs of shock. Remember yesterday in the previous video we talked about the signs of shock, hypovolemic shock, okay? you can't reverse the video, and in case you don't have the signs of shock, and they'll be there. Okay, so I'll continue monitoring my mother's condition. I'll put off my gloves, aprons, and wash my hands according to the WHO protocol. Should I give you a third one? Oh my god, you're finishing the emergencies today. Then we're going to do the professional values next. I want to move order by order. Anyways, so let's go into the third one. Okay, so another thing I want to remind you, remember to look at the marking criteria, and then if you need also revision materials, you can look for the NMC mock test criteria. Okay, so let's assume I've already the mother already knows me. I know the mother. Okay, so I'm going to go and I tell my mother I've already informed her this is an emergency, like in the previous. I've already informed her this is an emergency, so we need to act. I've already called the team. Let's assume all that is done. So still, we shall go on to recline the bed and make it flat, and tell the mother she needs and tell her this is to stop pushing because this is a bony problem. So then I'm going to ask my examiner, has my help arrived, to confirm that the team I called has arrived. Okay, so if the team has not yet arrived, I'm going to verbalize and go on that I'm going to put the mother in a semi-recumbent position. If the helper arrives, then I'm going to put the mother in a McRoberts position. Okay, so then remember to go step by step, so this will help you not to forget. So let's go on. First is the McRoberts position. If this does not help to widen, first is the McRoberts position because it helps to widen the pelvic diameters. Or remember, the McRoberts position is pushing back the mother's legs towards her abdomen. Okay, so ask your assistant to help you hyperflex the mother's legs towards the abdomen. Next is number 3. You're going to do suprapubic pressure. This is a hands-on technique. Okay, you're going to place your hands just below the symphysis pubis, locating the baby's shoulder. You go downwards and slide it into a lateral position. So you need to verbalize that you are not doing this for more than 30 seconds. If this does not help, we're going to evaluate for an episiotomy. Are we together? We are evaluating for an episiotomy. Remember, you should note that you do not give the episiotomy. That's why you go on to examine that, to ask the examiner, can I confirm my mother's vagina is roomy enough? I don't need to give is an episiotomy. Okay, so then you go on to deliver the posterior arm. Okay, so scrunch your arm into the cone shape, slide it into the posterior part of the vagina to locate the posterior arm. Locate the wrist of the baby and pull through an arm and drop it up by exotraction. Okay, if it does not work, now we are going to do the internal rotation maneuver. Okay, so you try to go above and locate the anterior shoulder. Remember, the first one was posterior, then we are now on the anterior shoulder. Okay, look at the anterior shoulder internally and try to rotate it and slide it under the suprapubic. We all know the suprapubic, midwives. Okay, so if that fails, we are going to support our mother on all fours. Remember, I told you not all mothers can go on all fours. Okay, so if a mother had an epidural before this happened, the mother cannot be able to go on all fours. So take note of that, and then confirm the mother has not had anesthesia, so the legs are mobile. If If it has not happened, the mother is okay to use this position. Mark that, okay? You can verbalize it to the examiner that if my mother has not had an epidural, I will support the mother to go on all fours, okay? Then you also need to demonstrate awareness of other maneuvers. So this needs to be verbalized for this. This is for other procedures that may be done in case all that has failed, okay? And remember we talked about the symphysiotomy and then the cephalic replacement. You know, those are extreme procedures, okay? Then let's assume the baby is delivered. So we are going to debrief the mother about what happened, then do skin to skin to encourage bonding of the mother, then perform the maternal observations, document, perform hand hygiene according to WHO, and remember to discard off your PPE in the clinical waste bin. Do it properly because even that can make you fail. Putting your PPE in the wrong place will make you fail. Okay, so keep that in mind too. Okay, thank you for listening in. That was the shoulder dystocia. So we're going to go into the professional value stations. Let me know if you have any questions about the previous emergencies that we've gone through. Remember the birth emergencies, we have a breech, PPH, and shoulder dystocia. Those three are done. We've discussed them like tubukunkumode, like I've put all them to. I've given you at least 2 ways of how to go into threes and the important points to note. Remember, ask if you need clarity on anything. I'm here to guide where I know. I'm going to share what I know. Okay, so remember to subscribe. Click that button so you are notified whenever I make new videos. Okay, so thank you for watching. Love you. God bless you all. Love you all.